So today's topic, we are going to talk about ambiguous loss and grief. Um, you know, I've worked with people who have dementia for at least 35 years, at 30 years at the Alzheimer Society and 5 years before that, working in a number of different settings, long-term care and out at geriatric outreach. But I also come to you as a family member, somebody who has had I always start sort of my talks off saying that when I was a young girl, when I was born, I was very lucky. I had 3 great-grandparents alive and a full complement of 4 grandparents. And out of that crew, 2 of my great-grandparents developed dementia, and I knew them and watched their disease change. And I also watched 2 of my grandparents develop dementia, and one of them lived with us for about 10 years during her journey. Since that time, I've had numerous aunts and uncles and cousins and a few friends actually develop dementia. So I know this disease intimately. And it is a very complicated family affair, as I like to call it. It's referred to in the literature often as the longest goodbye. There's a wonderful blog post that Alzheimer Canada puts online, which is www.alzheimer.ca. And every month they do a blog post. And this one by Linda Van den Broek and her mom, about her mom, was one that particularly hit me because it was talking about their journey together through the journey of Alzheimer's disease and how difficult it is and how it is a grief walk, really. And I've heard it referred to that way. There are countless memoirs out there about living with dementia and losing somebody with dementia. Families talk about losing people in pieces. There's also a body of movies that we can watch now about what it is, what this journey looks like. And many of you here online are walking that journey right now. One of the first books that I remember, memoir type of things was Patty Davis's memoir of her dad, Ronald Reagan, which was called The Long Goodbye. Another book that I read talked about death in slow motion. And then another book talked about the relentless goodbye. It is a journey that takes a long time for many people, and we'll talk a little bit about that this morning. I'm happy to see, though, that Patty Davis has a new book coming out called Floating in the Deep End about how caregivers can see beyond Alzheimer's and survive and thrive. And one of the new books that I read in the fall was a memoir by Jane Monroe, who talked about her life with her husband and coming to the end of that life in a book called Open Every Window. And that book has been compared to Joan Didion's book. I don't know, many of you may have read that one about her husband, which was called The Year of Magical Thinking, and it won a lot of awards. I would recommend the one Open Every Window by Jane Monroe. So Alzheimer's disease, it's not what you would expect. The loss associated with dementia is different. And I'm going to use the word Alzheimer's and dementia sort of interchangeably here. Quickly, Alzheimer's disease is one kind of progressive irreversible dementia. Dementia is the umbrella term. There's a lot of different kinds. Now, take a look at those pictures of people below. These were taken at our day programs many years ago. But these don't look like people who are sick. But indeed, these people are in the mid to the late stage of the disease. And I will tell you that everybody you see in those pictures, except the gentleman watering the plants, has passed. The gentleman watering those plants, while he was with our day program for about 5 years or so, he's been now in long-term care for going on 11 years. So it's a very long journey for many people. But the losses associated with Alzheimer's disease and dementia are a little different. I want to talk to you, and we're going to be talking today about loss and grief and death. And I'm pretty straightforward about it. And I purposefully sometimes use words that families get a little upset with me because they say I'm being a little harsh. But I want us to understand that Alzheimer's disease is progressive. There is damage that increases over time. No one is going to get cured from Alzheimer's disease. The disease is relentless and marches along. We may be able to help people to function as best they can with some supports and with medications and all sorts of different things, food, diet, hydration, but the disease is still there. This is a degenerative disease. So you see brain cells breaking down. They don't come back. It is irreversible. It cannot be repaired. And sadly, right now, we do not have a cure because we do not really know what causes it. We have answers. We have some of the pieces to the puzzle, but we don't have the whole piece to the puzzle. So this is a fatal illness. It's a fatal neurological condition that can last from diagnosis 8 to 12 years. And it's much more than just memory. I think many of us think about Alzheimer's disease as just being memory, or dementia as just being memory, but it's not. And I will tell you, for family members, that the grief is a constant yet hidden companion for everyone. And it's a companion at every phase of the disease. And that comes from Ken Doka, who was one of the first people who recognized and understood about the aspect of grief for family caregivers and for the persons living with dementia themselves. So this is a quote from 2004 and I think it's, quite profound, really. And I think we don't talk about it enough, that grief is something that accompanies everyone who is on the journey of dementia. I want to talk a little bit about the progression of the disease, because at each stage of the disease, there is grief, different grief for different reasons. One author that I was reading and preparing for this talked about different pinch points of grief. So when the grief can become very acute for you. So there are different stages. Some people talk about 7 stages of Alzheimer's. Some people talk about 5 stages of Alzheimer's or dementia. I'm going to talk and use what we use at the Alzheimer's Society, 3 stages: early, middle, and late. And the average lifespan from diagnosis is about 8 to 12 years. That being said, people can live for very long lives as well. I often use my family as a marker sometimes. And my grandmother was taking care of her husband, who was, she was his prime caregiver. My grandfather was diagnosed with Alzheimer's when he was in his late 70s, but he was showing signs from his early 60s. He did die at age 81, but my grandmother was doing a lot of that caregiving for him. And we saw her presenting with peculiarities, shall we say. She was doing things that weren't quite normal for her. We were seeing short-term memory loss. We were seeing her having difficulty concentrating. There are cognitive issues that we were seeing in those early stages, but we didn't recognize it as Alzheimer's disease. We thought she was just stressed out as a caregiver. Certainly didn't think that it could happen twice in one family. So like many people, we were taken aback. After my grandfather died in 1981, this very independent woman had a lot of difficulties, and her personality shifted. She was withdrawing from a lot of activities. She was a lady who was very active and very busy, but she suddenly wasn't doing any of those things. And she was starting to get lost. She would take the bus somewhere and wouldn't come back. So at that point, we as a family moved her up to Toronto with us. And at that stage, she was still fairly independent. She knew what she wanted. She made some interesting choices in her decorating of her apartment, but they were her choices. And she was having a lot of difficulty just organizing things. And she was having a lot of difficulty, with her routines and appointments and things like that. So what we ended up doing was getting her diagnosed, or getting her to a doctor. And certainly the doctor diagnosed her with Alzheimer's. And by this time, she would have been in her late 70s, early 80s when she was diagnosed. My grandmother lived until 2001. So she lived another 25 years after her diagnosis. She was in excellent health. And she lived with us as a family for about 10 years. And then she was in long-term care for 10 years. And I would say the first 5 years, this early stage of the disease, she was taking care of my grandfather and living on her own. People in the early stages of the disease may not have a lot of difficulty and are able to live independently. This stage of the illness often lasts 2 to 6 years, maybe a little bit longer, depending if the person is being properly supported. And these are people who may start to have some difficulty with things like banking and making appointments and maybe putting on a full Christmas dinner. Maybe they can still cook simple meals, but not the full dinner with all the trimmings. And they're starting to show changes with their independence. People at this stage of the disease may also be very aware of what is going on, and may be fiercely hanging on to their independence. And it may be difficult to present them with the supports they need. When we move into the mid stage of the disease, this is a stage of the disease that can last a short period of time, maybe 18 months, 2 years, but can also, again, linger for longer periods of time. And these are people who there's a test that we use called the mini mental status exam. And people are scoring between 21 and 10. That's a big gap, but it is a progressive disease. So people are starting to have more cognitive issues. They're having difficulty doing calculations, making decisions, planning, but they're also starting to have problems remembering their own personal history. They may not be able to recall all the places that they've lived in their life. They may not be able to recall all the jobs that they've had in their life, where 2, 3, 4 years prior, they wouldn't have had any difficulty with that. But you're also going to start seeing personality changes, and you're also going to see functional changes. Those functional changes are things like having visual spatial problems. People have difficulty putting their body where they need to put their body. They may have falls because they're doing a lot of tripping. They may have a lot of spills because they're not able to assess when they have something in their hand where they're able to put it, and it may miss the table and fall on the floor. Or they may start having issues feeding themselves and it dropping on the front of them. They also have a lot of sleep disturbances. And at this stage of the illness, we need to be very careful about people having missing incidences and getting lost, or people who are no longer really safe to drive. This is what I would call one of the pinch points, of acute grief. It's around that loss of independence, around driving, around being able to get out in the community on their own. One of the first pinch points is that time of diagnosis. And sometimes that time of diagnosis does not come until the mid stage of the disease. People are living okay early, and we're not getting people diagnosed early enough. When we move into the later stages of the disease, this is, again, another stage of the disease where people are maybe scoring less than 10 on a mini mental exam. It's out of 30. And these are also people who are really quite profoundly affected by their illness. Their judgment is significantly impaired. They're having difficulty doing normal tasks. Their ability to communicate has shifted significantly. And that's both expressive communication and receptive communication. So they're not able to really understand what you're saying. They may give the appearance that they're understanding, but they really haven't taken it all in. And there may also be two sides of a coin, really. People can be hyperactive, but they can also be very lethargic. And at this point in one's life, people are needing total care. The other thing that we need to remember that as the disease marches along, the disease is very physical in the end. People in the later stages of Alzheimer's disease have a very high risk for infections, whether it's a UTI or bed sores or other chest infections, or they have a lot of problems because their brain is not able to control things. So Also, people get very dehydrated. And when you get dehydrated and you lose weight because you're not eating properly and you're not maybe metabolizing the weight problem, the food that you eat properly, people end up with an awful lot of difficulties. And people die in the later stages, but they can certainly die in the mid and the early stages because of a secondary cause. Often it's pneumonia. Often it's their body's just not metabolizing the food the right way, and their organs start to shut down. So, it is very difficult for families to understand this very long process. And because people can present okay at certain times, it belies what's going on underneath. I know for us at the Alzheimer's Society, we've had that happen recently. We have clients that we've been working with for a very long time. And one of our dear ladies who attended our day program regularly for a couple of years, well, a few years, I think, prior to the pandemic. And then she came back when our day programs opened up in the fall of 2020 and was with us right up until December, when we had to close again, sadly, in January, our programs for a couple of weeks with Omicron. We had delivered her a gift bag. We did sort of activity gift bags at Christmas, and our staff saw her on the 28th. And we got a call, I think it was on the 1st, that she'd passed away, quite unexpectedly. Because she was basically looking the same. And I think it was a shock for us as the staff working with her. And we've had this happen a couple of times. We had another client who had a fall. She did break a hip. And she was supposedly healing and doing a bit better. She broke the hip on a Friday and she was gone by Monday. And we've had people in our day program who actually, was fine. They were active. They were participating in the program, but they went home from the program and that evening they passed away. So outward appearances for Alzheimer's don't always, people who are that close to death don't always look that way. I put this teaching tool up. It is not a very good copy, I will admit that, but it is probably, in all of my years of working with families and working with people, training staff, it's one of the best examples I've ever seen. You can Google it. You can find it on the internet. It's by Dr. Tang Wai. It's in the Canadian Alzheimer's Disease Journal. It's an old resource. It's about 20 years old now. But what he has done is he has put in column A or row A all of the stages of the disease. He also has sort of the length in row B, the length that stage. And this is just like a model. So everybody is unique a little going through it. Row C talks about sort of decision making and mental capacity for making decisions. This is something that I have when I'm working with families and they tell me, my mom's scoring 14, 15 on a mini mental exam, and she's still in the driver's seat about where she lives, how she conducts her life, but she's really struggling. I say to them, well, let's look at this map. And again, this is just a model. I said, well, according to this map, if your mom's scoring 14, 15 on a mini mental exam, that's line E, follow it up. She's making decisions like a 7 or a 5-year-old. Would you let your 7 or 5-year-old make a decision about where they lived, if they lived independently? There are certain things that you would let the 5 or 7-year-old, but big things, listing their house, driving a car, you might not. So I just find this to be a really helpful tool. And the other thing that it shows you is sort of this pattern of the disease, that the mild stage can take quite a long time, or that early stage. The moderate stage, where so much of the change happens, is really quite short. And then the severe stage, or the terminal stage as they talk about, which is our late stage, can last a very long time. But that very long time is dependent on other people's other health conditions, and also the type of dementia that they have, because people may have other issues that can make them even more vulnerable. So sometimes people who have frontal temporal dementia, which means they have a lot of behavior problems, sometimes no memory problems in the early stages, but a lot of behavior problems, make some decisions that are put them at significant risk and end up, unfortunately, because of the decisions that they've made, they die earlier than they might have. So the other thing is, I am talking about a terminal illness, and I am specifically using that language. This is a slide that was presented from Hebert and Merkel. There's a resource called the Brain Exchange. It's Brain Exchange. You can go on there. They have resources like you wouldn't believe. A lot of seminars that have been taped. If you're interested, you can listen, but they have a lot of written resources as well, and anybody can go on the Brain Exchange. So this was a presentation, and they talked about information that came out in 2014, 2013 out of American resources, but there's very similar to Canadian, that, it is a terminal illness for whether it's Alzheimer's, whether it's vascular dementia, whether it's Lewy body or frontal temporal dementia. We've talked about this already. It's progressive and there's no cure. What they found out, though, from their research, that the average was about 6.6 years from diagnosis to death. At that time, and this is now 10 years ago, this was the 6th leading cause of death in the United States and the 5th leading cause of death for over 65. I've seen recent statistics that those numbers have even creeped up a little higher. And we'll have to see how things play out with COVID, because COVID is certainly pushing some of the causes of death and skewing things quite a bit. And unfortunately, what we found with COVID too is that many people who died in long-term care, but also people living in the community who had Alzheimer's disease or dementia also died early. And that's probably due to some of the things that we've already spoken about that late stage and the ability to monitor infections and fight infections off. So, this is significant. In CIHI, which is our Canadian resource that tracks a lot of information, said that in 2011, there were 750,000 people who died as a result of dementia, and that they're predicting by 2031 that number will rise to 1.4 million people in a year. So there are certain things that are certain. And Murray and Robinson, again, out of a Sea Drake, which came before sort of the Brain Exchange, has also some wonderful symposiums or webinar resources you can get. But this was Murray and Robinson did a really terrific presentation. They're out of BC. They were one of the first people, I think, who did a Canadian presentation on grief and death and dying and palliative care for people living with dementia. The one thing that they did say, the things that you can be certain, that there is a decline over time, that each dementia is unique, so each person's trajectory through the disease is a little different. The death is certain. Well, it's certain for all of us, but for people with dementia, it maybe is a little sooner. And that, as I talked about earlier, that if you have other comorbidities, they affect that trajectory. So if people have COPD, if they have cancer, if they have heart issues, those things may affect and hasten the death. That certain interventions, and we know that certain interventions are no longer effective in the late stages of the disease. Things like, and I'm not saying don't do these things, because everybody's decision is individual. But we do know from research that CPR is less effective. And in fact, it's ineffective. And within 24 hours, if you do CPR on someone who has late stage dementia, only 3% of them survive. And that, so that's a very low response rate, survival rate. G-tubes don't necessarily improve the situation. They may just prolong the situation. That for IVs, antibiotics, again, don't necessarily improve They may only prolong because the immune system is already compromised. And that often transferring to a hospital from long-term care when people are at that end stage of their disease makes it worse for them. I mean, if they're in abject pain, you've got to do it. But if it's something that can be treated at home or in the long-term care facility, it has a less likely chance of causing delirium or responsive behaviors that are, not helpful. And what is difficult that many of us don't see those indicators that predecease the dying process or the active dying process, but those are there, and skilled people know that. I remember with my grandmother, she was in long-term care a very long time. And towards the end of her life, she stopped eating, like from about November. She'd eat once a week type of thing. And we all thought, oh my goodness, stuff is coming. But the nurses were very good. They said, no, it's not coming. She was able to survive quite well for a couple of months, 6 to 8 weeks. It wasn't until January when she started, she had infections. She had pneumonias, many pneumonias over the last prior 2 years of her life. But in January, February, those pneumonias increased. And and then she really just stopped eating completely. And there was discussion in our family and disagreement in our family. Put a feeding tube, we're killing her, we're starving her. And our family was Catholic. So you don't start something you can't stop something once you start it. And, we knew what her wishes were. She wanted to be with her man, with her Andy, who she'd been married to for 65 years, I think. And so I remember a particular argument with my dad and my uncle on the phone. Well, you call your priest, I'll call my priest, and we'll have a discussion tomorrow. And the decision as a family, after each of them went off to their own corners and had discussions, they realized that the feeding tube was not going to help the situation. We just made her as comfortable as possible. And I will tell you, she ate ice cream for little bits, but she did eat ice cream for those last 2 weeks. That would have made her really happy, for sure. I remember being at bedside with another client that I had worked with. This was a younger fella in his 50s, gone to long-term care. And I was just happened to be at the family's home, and he was not doing well. And we were sitting with I think there were 2 sons, a daughter, and the son-in-laws and the grandkids and the wife. And they got a call from the long-term care, and they said, I think it's time, he's going to go. And I remember, they called the priest, another Catholic family. We all showed up en masse at long-term care. We can't do that now, but there were, 10 of us around his bedside. And prayers were being said. It was a very solemn moment. And then we've been there about half an hour. His eyes popped open like this. And he said, what the hell are y'all doing here? This was his humor, but this was him. And again, the family had 5 situations like that, where everybody rushed with the priest to do the last rites. He had his last rites, I think, about a dozen times. And when he did go, he just slipped quietly away in the night. There is something when we look at Alzheimer's disease in the literature where they talk about ambiguous dying syndrome. So this is not ambiguous loss. This is Mercedes Byrne-Klug, who defined that it refers to the challenges when people are not identified as dying until they're certain that the death is coming. And what her argument is that perhaps we should look at people who have Alzheimer's disease with a palliative lens and get them to be able to participate in some of the decision making, some of the choices that they're making. You don't want to make people give up, but you want to open that conversation. I know personally when my parents were dying, and my mother had a very protracted illness for many years, we talked a lot about death and dying, about how she wanted things, how she didn't want things. And the same with my dad. We had a much shorter period of time with him. But, it gave her meaning to be in control. Now, neither of them had significant cognitive issues. There were some as things moved on for them. But, them being in the driver's seat, having those conversations with my sister and I, when it came time to have to make decisions, it was a lot easier because we knew exactly how she wanted things to be. We knew exactly how my dad would have wanted things to be. We couldn't do that with my grandmother. We sort of guessed because she didn't talk about it. We just didn't talk. And many families, when I'm working with families, one of the burdens and the losses and the things that make it so difficult for family members is they're having to second guess about their family member, about making decisions about end of life for somebody else, which is really hard. So this ambiguous dying is an interesting concept because what it does is it makes us think twice about how we approach care for people who are in their palliative stages, in their last years of their life. It might be a very long illness, but it certainly helps you to make some decisions maybe a little differently. When we talk about grief too, and as family members, we hear about the term anticipatory grief. So that's a grief that happens, or people think how it will be when the person passes away. And I know with my mom and my dad, we did a lot of anticipatory grief because it was time limited. We sort of knew when the end was coming. And we could do some of that grieving, and we knew it was going to be 6 weeks or it was going to be 8 weeks. And actually with cancer, they can get pretty close to exact timeframes. Now, my parents didn't have cancer, but they did have illnesses that they could predict sort of how long it would be. They surprised us a little, but both of them, for my family and our friends, we were able to anticipate when the end was coming. For my grandmother and my grandfather, we had no clue, and it was a very difficult process for us. In the literature, there's another type of grief where they talk about disenfranchised grief. So where really the grief is not acknowledged, it's not validated. If you publicly mourn it, you are not looked at that you're doing the right thing. And I would say that a lot of times people who die with dementia and those family members that are experiencing the grief, this is the kind of grief you're dealing with, which is called disenfranchised grief. And again, this is Ken Doka, and he was doing this work in the mid-90s, or early 2000. But along came a woman named Pauline Boss, who in the late 1990s came up with a term called ambiguous loss. And she's written a number of books. These are 3 that are particularly important, I think, for us when we're looking at Alzheimer's disease, because we're talking about, when you think about it, 25 years, 5 years, 2 years, 3 years, where you're seeing someone dwindle. That's another book that came out recently called The Dwindling. It is another memoir. But when you look at that, it's because these losses are different. They're not normal. You can't anticipate them. But it's an ambiguous loss. So there isn't closure. The loss is a little unclear. The person is there, but they're not there. There's a presence and an absence, both at the same time. And you, as the family member who is walking this grief walk, are looking for answers. You're searching for the answers. It really stresses and complicates the grief process. Families feel like they're put in limbo. You can't move forward. I can't move backwards. And really, it's not recognized and it's not understood. So her seminal book came out in 2000. That was called Ambiguous Loss, Learning to Live with Unresolved Grief. And a lot of that work was around sort of soldiers who didn't come back and with their families. They didn't have a body. A lot of this came after 9/11 because people just vanished and they didn't have a body to do those normal things we do when someone dies. Her work got taken up, and in 2011, she wrote specifically a book about loving someone who has dementia and about that experience for people living with dementia. And this is a new book, which I have put in order. It's in back order. I haven't got it yet, about the myth of closure. Because really, in pandemic, you haven't had the ability to close. You know, those rituals that we have, funerals, wakes, all of those things. During the pandemic, we haven't been able to do it. Many of you have probably lost family members. Many of you have lost probably family members in long-term care and haven't been able to grieve. So this term is really, I think it fits very well for people living with dementia. You know, this again from another study that came out in 2007 about how dying with dementia is different because there is a social death really that precedes the actual death. You know, it's difficult for people living with dementia to be fully engaged in their life and also feel fully engaged in what their wishes would be and what their preferences are, because by the time the diagnosis is made, it's often too late. And that process can be protracted. It can be long. I think of that family that I worked with in Woodbridge who were called to the bedside 7, 8 times for last rites. And, you know, you get prepared for the death and then it doesn't happen. You know, there's it's so hard to continue that walk. You know, families that, and there's a few people that I saw on the admission list, people that we've known at the Alzheimer's Society 10, 15 years, and they're still caregiving. You know, it's exhausting for families. I mean, I've been here 30 years. There's a couple of families that I've worked with who they took care. They were the primary caregiver for their mother. Then they were the primary caregiver for a sibling or for their spouse. So this walk of dementia for them has been 30 years, 40 years. It's such a long time. And it really, people get exhausted and they withdraw. So, you know, the other thing that I'm going to say to you and what Small and Froget and Downs put forward is that we really need to be looking at Alzheimer's disease with a palliative lens. And what do I mean by a palliative lens? I mean, looking at quality of life, looking at reducing suffering, treating pain and the distressing symptoms. You know, I've had more than I can count clients who have arthritis. They stop getting their pain medication. They start acting out in responsive behaviors. And families say, well, that's the disease. Or the doctors even say, that's the disease. They're just getting worse. Hell no. Give them a pain medication. They've been on the pain medication for 40 years. And suddenly you stop it? They're in pain. Give them their pain medication. A palliative lens looks at the whole person. They look at the holistic, the spiritual, psychological, and as well the cultural. You know, those things are very important to people. And people with the disease sometimes they all revert. So what are memories that is important to them and is current and present to them are things that happened in their youth, in their childhood. So, you know, for me, I grew up in Windsor, Ontario. I talk about that a lot. So you're going to have Verner's ginger ale for me, not Canada Dry. You're going to have Lay's potato chips, not the other kinds of potato chips, because those things are, you know, food is very important. And I had things that I remember from my youth that I will probably crave those things again. So, you know, I think that that's a little tip for you when you're working with people. And I mean, the other thing too is when we're looking with a palliative lens, we're looking at not just supporting the person who has the illness, but you look at supporting the whole family, that whole unit. You know, when research is done, you know, we have 500,000 people in Canada who are now living with dementia. In York Region, probably about 18,000 people living with dementia. For each person living with dementia, the research shows that there's close to 10 or 12 people who are affected by that person's dementia. So we need to support everyone through it. And really, for those of us working in long-term care or in the community, we really need to adapt a team approach. And you at home, as the caregiver, you need a team approach. You cannot do this alone because of the length of the disease. And what research has shown us about caregivers, this is, standard research. It's been around for 25 years. A lot of this comes from a study that first came out in 1999, where they detailed the comparison between dementia and non-dementia caregivers. And, caregivers are often seen as the second invisible patient. Often when people go to the hospital or to the doctors, they only ask about the person with the disease. They don't ask about the caregiver. I learned a really good lesson when I was in my placement, and I had the pleasure, Dr. Willie Malloy, and you probably heard about him. He was one of the first people in the profession. I think he's a neurologist. He worked out of McMaster. I was able to go with one of my clients I was working in one of my placements. And he was interesting because when he got the couple into his office and he let me come in, he didn't really ask about the person with dementia because this person was far into the disease. He looked at his wife and he said to her, "What are you doing for yourself? How are you doing?" A lot of people don't ask. Anyway, these are some of the things that caregivers report. And in fact, in 2015, CIHI, which is again our Canadian researching company, they found that, agency, that the job of taking care of somebody living with dementia shows their caregivers have higher rates of burden, higher rates of depression. They spend more time with providing care and support. And in fact, they're 45% more distressed, and they're 2 times as likely to report distress that's related to physical or verbal aggression from the person they're taking care of. These are some normal feelings. These are all normal feelings that caregivers go through. Guilt, depression, fear, any of these things. I put guilt at the bottom, but it's probably one of the highest. And grief is normal. How does this impact the caregiver? Well, it certainly, in fact, impacts the caregiver's health. It impacts their sleeping because they're listening with one ear for the person to get up. They're not eating well. They're often not exercising because they're running around taking care of the person who's ill. They don't stay in bed when they're sick. They don't go see the doctor when they're sick. And sometimes they use different mechanisms for taking care of themselves. I have a friend of mine, I have a number of friends who've been taking care of their parents because we're in that age group. And one of my friends, often says, well, it's a 3-drink night or it's a 4-drink night tonight. When you're in the midst of that, it's challenging. I've had caregivers one of my caregivers who was dealing with a younger husband, they had no children and very limited family. She was someone who drank a little too much, and she was on antidepressants. And unfortunately, her life ended because of a mistake. And she wasn't there for her husband. I think she drank a little too much and she took a few too many sleeping pills and she didn't wake up. And that is something that we need to be aware of for caregivers. Now, I really do sound like I am negative Nelly. I don't mean to be, because there are things that can be done. And I think one of the things we need to do is to name the grief. We need to validate that grief is normal. And we need to call it what it's called. It's called ambiguous loss. One of the biggest things that we need to do is accept the disease and accept our family members. I've seen so many caregivers that I've worked with that are struggling, trying to make things normal or like they used to be, but they can't be because of the disease. can come close. You can try to change things, but you cannot have what was there 10, 15 years ago. One of my clients that I worked with was a nurse, and they used to, I don't know, any of you old nurses out there? Nurses like to, especially nurses who graduated in the 50s and the 60s, they get together every 5 years and have, get together, or even every year. And my aunt, who was a nurse, they were doing it every week, pretty much. But one of my clients that I worked with, she was having a reunion up in Ottawa, and she so wanted to go to this reunion with her husband and have it be normal. Well, it wasn't normal. It was, in fact, quite disastrous. She was so upset. She got him all the clothes that he needed to wear. She made all of the arrangements. But she was going to do this. So she took her husband, and sadly, her husband, who was a police sergeant. He was a huge guy, 6'4", well over 200 pounds, still solidly built fella. But he behaves like a 2-year-old with a temper tantrum when he didn't get his way. And she was just horrified at the luncheon because he spent most of that luncheon under the table kicking his feet. Literally, he got underneath the table. She was embarrassed. She was upset. She was angry. She was madder than I've ever seen her at her husband. But thank God for her fellow nurses, because they got her to a point of accepting that nothing was normal anymore for them. And they just adapted how they did things. So that acceptance of the disease is important. And I think you get acceptance and understanding by education. So being here today, understanding what's normal, what's not normal, given the disease and where the person is in the disease, is really important. I have a dear gentleman who's been attending my support groups for, 15 years. And every single support group, he quotes the Serenity Prayer, because he said this is what's gotten him through. And he's on about year 18 of caregiving with his wife, and she's still at home. He's amazing that he's been able to do that. He always says that, God grant me the serenity to accept the things that I cannot change, the courage to change the things that I can, and the wisdom to know the difference. And it's that wisdom, I think, that will get you through this disease. The literature talks about dual thinking and engaging in that. And it's the practice of thinking both and. So you can be both a caregiver and a person who has their own needs. You can say to yourself, I wish this were over, but I really want my family member here. I'm really sad that my husband has this disease, but I'm joyful about my new grandchild, or whatever. That both and is much better thinking than either or. And the literature talks, Boss talks about making peace with ambiguity. And ambiguity means sometimes things go unanswered. You can't fix all of the problems, especially with this disease. You cannot control this disease. This disease is going to move forward. It's again about that acceptance of what you can change and knowing the difference. Maybe you learn some new skills. Maybe you learn, caregivers are the most resilient people I've ever met in my whole life. I had an 85-year-old, I'm trying to think, I think he was 85 or 87-year-old caregiver who came in to my day program. Without an appointment, he just skipped his way in there. And he was so excited because he figured out the laundry machine. That was something he'd never done. It was always his wife's domain. But for him, it was a huge accomplishment. I've worked with women caregivers who their husbands had always done all the outside work, right? Or had looked after the car. One of my caregivers had never pumped gas, and at 80 years old, she learned how to pump gas. And she said, I don't know why I thought that was such a hard thing. But there's grief associated with that. It is sadness to know that your spouse, your partner is not there to do those things anymore. But there was also an accomplishment for her. So that dual thinking for her worked well. And that there's ambivalence, ambivalence is something that's normal. There are always mixed emotions and mixed feelings. If we don't accept it as normal, we don't acknowledge it, it can fuel negative relationships and destroy one's resilience. You've got to make peace with both ambivalence and ambiguity. You need to restructure your attachments. And Boss talks about holding on while letting go. So what does that mean? It means maybe some new relationships, maybe celebrating the good days when there are good days, and understanding that relationships change. Maybe your husband or your wife or your spouse is no longer your go-to person for everything, and you have somebody new who's in that position. You have to also look at revising your own self-identity. You are maybe a caregiver and a daughter. I had a younger client that I worked with who referred to himself as a spouse without a partner. And the literature talks about building a new psychological family, finding new human connections. So those would be perhaps peer support groups, long-term care families. When we were able to go into long-term care, a lot of relationships developed between the family members when they would be visiting. And also taking control of your own self-care. Boss states that minding about yourself is not selfish. In fact, you are doing the person that you love or you care about the biggest thing you can by taking care of yourself, because now your needs are primal to be able to stay healthy and to stay strong. Here are some tips about resilience and things that you can do. Peer support, whether it's education groups, whether it's mindfulness groups, whether it's any type of group that you want that will help you get a new peer group. I know at the Alzheimer Society, we do a thing from Mount Sinai called the Enhanced Carers Group. It's an intensive group, and it teaches you how to communicate a little differently. If you're interested in any of these groups, come and talk to us. We have mindfulness groups that also go on. You want to identify the people in your life who are there for you. So you want to expand that circle. It's really quite amazing. I hear from caregivers all the time saying, those people that I expected to be there, they're not there. And the people who I didn't expect to be there are there. So whether it's the neighbor, whether it's somebody from the church group, whether it's, the young kid down one of my clients, for her, she didn't have any children, but there was a teenage kid down the road who helped her with the shoveling of the snow. It was an amazing thing to watch that relationship grow. He became like her surrogate grandson, and she valued that partnership or that friendship after her husband went into long-term care. And so did he, actually. You have to be able to give yourself permission to take a break. There's one client that I had that I would have to sit there and tell her, okay, it's time for your weekend, go away. And she'd say, oh, can I? I write her a prescription, take a break. I learned that from other clients. There was a fellow in our day program who, again, was a prime caregiver for his wife. And every weekend he would book himself an overnight. They had the funds to be able to do it. They lived in Thornhill. He drove up the 404 to the Comfort Inn in Newmarket, and he would be there Friday night. He had friends who would come and stay with her until Saturday evening so that he could read the newspaper, listen to the music, and not be interrupted. That was his thing. And sometimes it takes a little bit of time, not a lot of time, to give yourself that break. Other tips, revising, not ending family holidays, celebrations, and rituals. You maybe can't have the big family Christmas do, but you can have a smaller do. You can do things a little differently. You need to understand that certain events and stages can trigger you and make it much more difficult, those pinch points that were talked about. You need to acknowledge and affirm your own strength and resilience, and maybe look to some things that you wouldn't have ever done, some arts, crafts, journaling. One of my clients, when her husband went into long-term care and she had a lot of time to do with herself, she said, I'm going to become something I've always wanted to do, which is an actress. So she joined the Curtain Club in Richmond Hill, and I went to her very first performance. She was 87. She had a one-line walk-on. It was amazing. She was a new person. She lived till she was 95. Her husband passed away, I think about a couple years after that. But every year she was on stage, and that really broadened her life. And you need to really start thinking about your own future and preparing and planning that life is going to be a little different. And how can you look at this as an opportunity, at the same time grieving and letting go? That peace that Pauline Boss talked about. And when I was grieving, I was told by a lot of people to be gentle with myself. I didn't know what the heck that meant, but now I do. So be gentle with yourself. Don't be so hard on yourselves. There are a couple of resources that I would say, please go to the Alzheimer's Society Canada and download them. You're going to get a copy of this PowerPoint so you can access from here. This is a resource book that was put together for individuals and families. And there's a little quote there that's on the front, because really that ambiguous word is something that's new to a lot of people. And, that ambiguity, as she says here, is exactly what I feel. And for some of you who are professionals out there, you need to understand that, again, this walk is a little different. Family caregivers are all grieving. They are all grieving, and it is important to understand that when they come to your room, they present in different ways. They might be really angry. They might be really sad, but they are all grieving, and we all grieve in different ways, okay? And I always like to end things with Teepa Snow. If you haven't seen Teepa, Google her. She's quite amazing. But her one of her quotes that sticks with me is "Let go." You need to let go how it used to be. You need to let go how it should be. And you need to let go how you should be. Thank you. I was on a conference call with Dr. Sharon Cohen, who's one of our Canadian leaders in research, and she's quite amazing. She's at the Toronto Memory Program. You can look them up. They're in Don Mills. She's doing a lot of research, and it is so difficult sometimes to diagnose Alzheimer's disease because a lot of different things can look like Alzheimer's disease, and people think that it's Alzheimer's disease, and it may be something that's treatable, something like depression or some biomedical deficiency in minerals or something. So it's really important to get that medical workup. But if you're concerned as a family member, and a lot of family members are, you might want to enroll in some of her research projects where they do all of the testing. And what's really exciting, we haven't got it here in Canada because of the cost of it yet, but they can diagnose Alzheimer's. I mean, it used to be that it was by exclusion more than anything else, but now we have blood tests and biomarkers and PET scans that they can do, but they're not as readily available in Canada for just general population, but they certainly are part of research studies. So if you're interested, I would say reach out to Dr. Cohen and her team and see if you fit any of their criteria. They can do. I know I have had a couple of my friends who are very concerned because of the family history that they have reached out, and they have and actually clients as well, because they're concerned for themselves as family caregivers or as their children, and they've been a part of research studies, and some of their fears have been allayed. Some people, the reality of what's coming is there, so they can make appropriate choices. No, I wouldn't. When you look at what are your risk factors? Okay, risk factors, female. Risk factors, getting older. The highest risk factor is age. A growing body of literature about things that we can do to protect ourselves, things, those good things. Eat well, drink lots of water, exercise, stay socially active, all of those things. So, heart healthy things. There's a whole literature now looking at diet. And we can send you some of that information, but you can find it on the Alzheimer website. So treatment right now, we have treatment that treats the symptoms. Things like Aricept, Exelon, and Rimonal. And there's a new one that's Alcabanab. I'm not saying that properly, but that's it's like a transfusion type of a treatment. And that has just recently been approved down in the States. And I don't think it's approved up here unless it's in a research project. That is challenging, but it's this disease is not a sprint, it's a marathon. And I think you as the caregiver, as the paid professional caregiver, we got to park ourselves sometimes. We don't know what's best for the people. We can see that, they're getting burnt out and they might want some help, need some help, but you have to go slowly and you have to go at their pace. And, people, spouses, you make commitments to people, death, till death do us part, sickness and health. And sadly, some of the times I've seen caregivers choose to martyr themselves. They lose their life. And it sometimes takes a very frank talk with family members saying, okay, that's fine. You want dad to die at home. Let's talk about what that looks like. Let's talk about, the supports you need and what would happen if you get sick. How are we going to manage that? When you're on an airplane, what happens when they do here are your exits? The oxygen comes down, put it on yourself before you help the person next to you. I was a lifeguard for years. You look after yourself first before you help somebody else. This is finding that balance is very difficult. You can't force her to take the pills unless you can figure out another way to get the pills into her, mushing them up, putting them in jam. Long-term care has done that for a very long time. I know it's maybe not kosher to do that, but if it's what makes her have an easier life, that's one thing. But if there's something that she likes, if your mom wants to eat ice cream, let her eat ice cream. Okay, so if she wants to eat cake and you might be able to get the medication in, but it is a balance. It's that balance. You can't explain it. You just say, I will tell my mother. And then you say to your mother, I love you.
Yes.
This is that accepting of the disease. It is so hard to, look to your parent and not get the acknowledgement. I don't know. I went down a rabbit hole last night because I couldn't sleep because of the pandemic. So I'm on TikTok and I found Alzheimer's TikTok. Some of it is, I was weeping. Well, I'm a weeper anyways, but some of the things that these caregivers were sharing with their family member, some of it not good, but most of it is quite amazing to lay it bare that much. And, I think one of the things too, you can learn from other people in terms of how they interact. And, there are some amazing, the Glenn Campbell story that was on CNN, to watch his wife deal with him when he was raging about whatever. If you can find it, there's one that a dutiful daughter, complaints of a dutiful daughter. It's from 20 years ago, actually probably 35 years ago, about a daughter with her mother, and it walks them through the disease. It was on PBS. One of the most amazing things, because the mom got to a point where she didn't know who her daughter was. She just thought she was somebody nice who came to visit her, and she had a nice friend with her. The daughter was so upset. I think I read about this too. She was so concerned about telling her mom that she was gay and this was her partner. But that all disappeared. Her mom they had a great time because the daughter learned to just be there with her mom.
Right.
And, her mom thought they were all sorority girls and they used to sleep in the attic. And the daughter, you watch her saying, okay, tell me about that. What was that like? Well, I would say many things if she's okay with touch, tactile things, rubbing her feet, massages on your hand, that type of tactile things, bringing things in that she can smell. If she is able to eat things that she likes, music, and music that she likes, music that relates to her. So, the gentleman who I spoke about earlier, who had a wife in long-term care, and he referred to himself as a spouse without a partner. The two of them were country western dancers, and he had figured out some way to have a constant loop of country western music going on in her room at long-term care. It drove everyone on the floor crazy. And I remember him getting really upset with the nurse who would come in and turn it off because she didn't like it. And he said to her, I don't care whether you like it or not. This calms my wife. And this is what she's going to listen to. And this is what you're going to listen to when you come in to provide her with care.